story serious case 2. Today we'll talk with very important topic for everyone dealing with emergency situation, which is the value of critical care ultrasound in acute pulmonary edema. This is a case of the 52 years old patient admitted to ER because of acute cardiogenic pulmonary edema due to severe hypertension and acute coronary syndrome based on ECG and X-ray chest. The patient blood pressure was shooting to 250 over 130, and the patient complained of chest pain, and the ECG changes revealed inverted T wave in the inferior lateral leads, lead 1, AVL, 2, 3, AVF, and starting from V2, 3, 4, 5, 6, all inverted, and there is voltage criteria, and there could be repolarization changes of voltage criteria in the left ventricle. Based on these ECG changes and chest pain and the pulmonary edema, and the X-ray chest, which was wet, denoting opacities in both sides, with prominent hilar congestion here, cardiomegaly, dilated aorta, as they consider the patient is hypertensive emergency and acute coronary syndrome, and start to give anti-ischemic medications, nitrates, dual antiplatelet, and they were liberal in Lasix giving, because they give 60 milligram IV BID, and the patient respond well. And next day, I was asked to assess the patient by ultrasound to explore what's going on and how can the critical care ultrasound affect the management of this patient. I start my assessment of critical ill patient by looking for the inferior vena cava. In this patient, I need to assess what's going on as regard volume status after giving Lasix, and the patient bath a good amount of urine. You see here, inferior vena cava is collapsing almost 80%, and the hepatic vein, even hepatic vein, is on the narrow side. Hepatic vein on the narrow side, 80% collapsing. That means already the patient on the dry side, and the Lasix did the job, and the patient improve with the Lasix. Next, we'll go almost after you checking inferior vena cava. Please go to the heart, to 4-chamber view, to see what's going on as regard to contractility. In this patient, it is ischemic heart disease. You need to assess the wall motion abnormality, and contractility for this patient is very important. Is there any any heart failure or not? You will see in this patient with 4-chamber view, the contractility is well. You are talking about at least 50 to 60% ejection fraction. You will see the septum is thickened, going with hypertensive heart disease. I didn't see any wall motion abnormality in this view really. Lateral wall is thickening properly. Apex is okay. Septum is thickening properly. That means this view give the impression of hypertensive heart disease. The color view on this 4-chamber and 5-chamber view, because the aortic valve is appear here, is going with, you will see, look for the aortic area. Look for the aortic area. You will see this clear aortic regurg, at least moderate aortic regurg, going with the diastole here. Blood, mosaic flow going from the aorta to the left ventricle. We need to assess the situation in parasternal long axis view. You will see very clear aortic regurg here with the diastole. You will see the moderate aortic jet of the regurg from the aorta to the left ventricle. You will see here a septum which is a bit hypertrophied and seeking well, but look for the inferior wall. It is really, look for the inferior wall. It's hypokinetic compared to the septum. Hypokinetic compared to the septum. You see the septum is seeking well. The posterior wall is not seeking proper. It is hypokinetic compared to the septum. For this, till now, we'll try to complete the picture now. The patient has moderate aortic regurg, has hypertensive heart disease, has hypokinesia of the posterior wall. This all going with the diagnosis, which is hypertensive emergency with cardiogenic pulmonary edema. But what else we need to confirm in these situations? Let us see for the EMA mode. for the pulsed wave Doppler of the aortic area. It revealed برضه clear aortic regurg here. Aortic flow here is no evidence of any stenosis. It's only aortic regurg. You see here, this is the Doppler, pulsed wave Doppler. You will put the cursor here in the aortic valve, and you will see the flow of the blood going through, away from the probe, here. It will appear on the negative side, which is this ejection aortic flow, and the regurgent flow, because regurgent flow will go through the probe from the aorta to the ventricle, towards the probe, from the aorta to the left ventricle. It will appear in the above the screen. You will see in the above the baseline. Okay, you will see above the baseline because it's going to this regurg type. Okay, we always talk about critical care ultrasound. We always talk about the complete story. Now you get inferior vena cava, which is in the collapsing sites. You know about the cardiac situation, which is moderate aortic regurg, hypertrophied myocardium, hypertensive heart disease, a bit ischemic heart disease because of hypokinesia of the inferior wall. Now we need to fit the puzzle together. What about diastolic dysfunction? Because diastolic dysfunction is very important to clue about the left side pressure, which is the wedge pressure. If you see here, it's very clear when I put the pulsed wave cursor here in the tip of the mitral valve, and I will assess the diastolic flow. It is only grade 1 diastolic dysfunction, which is delayed relaxation. That means, yes, Lasix did the job. He makes the patient on the hypovolemic sides, and at the same time decrease the left atrial pressure, which is the wedge pressure, because grade 1 diastolic dysfunction is going with low left atrial pressure. This will complete the story. Your patient, our patient is in the good track. He is in the dehydration sites and away out of pulmonary edema now. Okay, what else? Lung water. Now, collapsing inferior vena cava, early grade 1 diastolic dysfunction, which is denoting decreased wedge pressure, and at the same time, dry lung. Started to appear A lines in the lung. A lines in almost all the lung zone. There was an A line, and the pleura is very thin here. When I measure the pleura, it's 0.17. That means the patient really now in the dry side. Ultrasound give us a very important clue now for this patient management. Patient is dehydrated side, on the dehydrated side now, and we can think about stopping Lasix at this situation because already the patient on the dehydration side. We don't need to exaggerate this situation and increase the dehydration of the patient and go into the common scenario in the ICU, which is pre-renal impairment because of severe dehydration. Okay, what else? This really A-lines was present all over lung zone. But when I go to the left lower lung zone, I find this situation. A-line, going with B-line, thick pleura. I will stop here. If you see here, I will stop here. You see, in this area, I get thick pleura, subpleural consolidation, and B-line. So, in the left lower lung zone, there is some other process going on, which is most probably in this patient, it's a patch of infiltrate, it's infection, it's lung infection, and this may precipitate all these problems for this patient. This may precipitate and encourage acute cardiac pulmonary edema. You see again, compare between this thick pleura, subpleural consolidation, and the B-line, and alternation with, you see, thin pleura, A-line. It's amazing pictures. I always consider this picture as ping pong pictures. One space you will see dry lung, and other space you will see infiltrated lung, and this always going with inflammatory infiltrate, not going with congestion. We will talk about a lot of times about the difference between pulmonary congestion and the pulmonary infection. But now, please, See again, this ping pong picture, which is one space, infection, one space dry, one space infection, one space dry. So let us now complete the picture and fit the puzzle together. The patient, this patient, after ultrasound assessment, he has a batch of chest infection. He has got recent chest infection, which precipitate this acute cardiogenic pulmonary edema. It's a mixed picture. And after clearing up the cardiogenic side and the congested sides, it became clear the infection sides. Now we can say ultrasound help us a lot in the diagnosis and at the same time help us in the management. Now we can say clearly, stop Lasix please, and you can start antibiotic. طيب, traditionally speaking, always talk about X-ray chest. Let us see X-ray chest next day. This is the X-ray chest. You now see it is cleared pulmonary edema, but you see in left lower lung zone it is hazy. But it is impossible during the acute pulmonary edema to differentiate between what is the cardiogenic element and what is the infective elements. Thanks to ultrasound machine, which help us in this very, very critical situation and very common. And thank you for all. See you in the next case, inshallah, in the complete story, critical care ultrasound. Bye.